I'm Dan Cooperstein.
And I'm Dot Summers.
And Dot and I are happy to be here with you today, presenting from our homes in light of the continuing worldwide pandemic. If you're new to our program, this show is about presenting you with the really important health and welfare benefits compliance news, and of course, discussing the impact of these developments on your benefit plans, without getting political, of course, because, well, that's not what the show is about. Although today will be a little different than what we've talked about in the past, as we'll be talking today about the recent election and its likely impact on your benefit plans. But of course, as always, we're not going to be taking any political sides here, just reporting on the facts and analyzing potential impact. And just as some background on me and Dot, Dot and I work together at Corporate Synergies, overseeing the national benefits consulting practice, helping clients out in all aspects of employee benefits, compliance, and regulatory matters. Dot brings over 20 years of experience in benefits consulting, including experience working on the front lines at HHS, to our team, and is really in many ways the mastermind puppeteer behind the workings of our operation. I bring 15 years of experience practicing as a lawyer in employee benefits and executive compensation matters, including representing health plans and health plan sponsors of all shapes and sizes with plan compliance, plan litigation, and DOL, IRS, and other government agency audits and investigations. So today we're going to be learning about how President-elect Biden's administration could likely impact and potentially change your health and welfare plans and insurance arrangements in 2021 and beyond. And specifically, our agenda and main learning objectives today are one, discussing recent developments that pertain to your health and welfare plans in our compliance update segment of our program, and secondly, major policy initiatives of the President-elect Biden's administration. And third, we'll be talking really, we'll go over what those major policy initiatives are, and then finally, we're going to really kind of zoom in, focus in on the big ones, right? The ones that will have a big impact, and kind of discuss their impact on your organization's policies, as well as potential, compliance issues and exposure to audits, lawsuits, and other potential liabilities. So that's the program for today. And Dot, before we get started into the election part of our program, why don't you get us started on our compliance update segment?
Sure. And unfortunately, these days can't really start any presentation without kind of what's on everybody's mind, and that is, the current pandemic developments. And, unfortunately, on the negative side of things, as most recently as the end of November, we did see, cases go over 13 million and deaths, exceed 260,000. So, as we're moving into these winter months, we certainly are seeing, increased spikes in cases, unfortunately in deaths. We're seeing a lot more states that are putting back restrictions on restaurants, schooling, even advisories on, possible stay at home, and, just a lot more, restrictions and things that are happening. But on the more optimistic side, though, we are looking to be much closer to a vaccine rollout at this time, at least closer than probably where a lot of us thought we were going to be at this point in time. And now that we have two COVID-19 vaccines that will likely be available soon, beginning this winter for the most vulnerable parts of our population, and that due to the CARES Act will be available without cost sharing on group health plans. So, I think that's really great news. And Dan's going to talk about those two vaccines and, some of the programs that will go along with that.
Great, thanks. That's right, Dot. And specifically, right, we saw these two potential vaccines, one from Moderna that has a 94.5% efficacy, and one from Pfizer BioNTech with over 90% efficacy. They're both showing really a lot of promise and getting quite a bit of media attention. These, as background here, the U.S. bankrolled Moderna's efforts, providing nearly $1 billion in support in a partnership with the National Institutes of Health. They initially found that the vaccine protects monkeys from the coronavirus. Then in March, the scientists were the first to put a COVID-19 vaccine into human trials. Then after those studies yielded promising results, phase 3 testing on 30,000 volunteers began on July 27th. And then on November 16th, Moderna announced that a preliminary analysis of the trial indicated that the vaccine was 94.5% effective. And those results came just a week after Pfizer-BioNTech made a similar announcement about their own vaccine, which, like the Moderna vaccine, is also based on an mRNA molecule encoding the spike protein. So it's a bit unique and not like past vaccines in that these vaccines don't actually include any virus in them, but rather they manipulate the mRNA in such a way as to train your body to fight the coronavirus. So at least for some people, that's promising, that they're not being affected with actual coronavirus when they get the vaccine. Although for many others, of course, there are concerns about the fact that this is a new vaccine technology and the fact that we may not know what all the long-term impacts might be at this point. And of course, the most promising thing here, from the group health plan perspective is, as Dot noted, under the CARES Act, these vaccines will be available on all group health plans without cost sharing, which is very good news. And as far as implementation goes, the U.S. federal government has launched this Operation Warp Speed program, which aims to distribute 6.4 million doses of a COVID-19 vaccine to states 24 hours after it gets emergency approval from the FDA. And officials are in the midst of dry runs to prepare for that implementation and the shipments. The White House's Operation Warp Speed is a joint initiative between the Departments of Health and Human Services, or HHS, and Defense. It aims to distribute the vaccine. It gave an update to reporters on the Tuesday before Thanksgiving, indicating that they expect the FDA to grant emergency approval by mid-December. And some are saying it could happen by the end of this week, so it's very exciting. More recently, the FDA's Vaccines and Related Biological Products Advisory Committee, or VRBPAC, scheduled to discuss the Pfizer-BioNTech request for emergency approval on December 10th. It is scheduled to request to discuss it on December 10th, and the Moderna request will be discussed on December 17th. Also, the Advisory Committee on Immunization Practices, or ACIP, a group established by the Centers for Disease Control and Prevention, CDC, met on December 1st of 2020 and offered recommendations on priority groups for vaccination. And of course, as this process goes full speed ahead, there's still many unanswered questions about how each state will distribute and administer the vaccine, including how to handle logistics, cold storage, and staffing. But from our perspective, right, as benefits consultants, right, we're getting a lot of questions from employers and plan sponsors about the vaccines, including a common question of, well, can we mandate that all employees take the vaccine? And the answer to that is a generally yes, but right, there are a lot of compliance-related considerations that you will need to take into account. And from an employee benefits compliance standpoint, it's important to remember that any kind of mandatory vaccination program is, in fact, a group health plan, since it involves immunization, which is considered medical care. And accordingly, from a benefits compliance standpoint, it'll be treated, much like a flu vaccination program, and therefore it would have to meet the ERISA and other group health plan requirements, including the requirement to have a plan document, Form 5500 filing requirements, and of course, the need to offer that plan to employees on COBRA, which of course can sometimes be difficult. So from an employee benefits compliance standpoint, well, it's far easier to not have a mandatory vaccination program. Instead, to simply educate employees on the fact that the group health plan offers vaccination for COVID-19 with no cost sharing under the CARES Act. However, all that being said, right, the far more challenging compliance questions with regard to mandatory vaccination programs come really from the labor and employment law side, right? Labor and employment law compliance. And while obviously Dot and I are benefits consultants, not experts in labor law, generally speaking, if your organization is absolutely set on mandating coronavirus vaccination, then you're really going to want to make sure that any such program has exceptions for employees with bona fide disabilities and religious objections. And we expect the EEOC to release more guidance on what employers can and cannot do with regard to return to work vaccination programs under those applicable employment laws. To the extent that you don't have exceptions or accommodations for protected disabilities and religious exemptions built into your policy for your mandatory vaccine program, well, you're probably going to be looking at lawsuits and grievances filed by employees claiming that the employer's failure to let them take advantage of one of those exceptions violated their rights under the ADA, Title VII, and other workplace discrimination laws. So while we can, we could probably talk about that we could probably do the whole webinar on just that one topic. Let's talk about another promising development that does pertain to your group health plans and with regard to the pandemic. There's also now available a new promising treatment that has recently obtained emergency use authorization from the FDA that will also be available without cost sharing, and this treatment is called monoclonal antibodies. These are essentially manufactured antibodies that received a lot of media attention after the president, Chris Christie, former governor of New Jersey, and Ben Carson all took them and recovered from the coronavirus. Ben Carson credited his recovery to the medication, saying in an article published in NPR.org that, quote, President Trump was following my condition and cleared me for the monoclonal antibody therapy that he had previously received, which I am convinced saved my life, unquote. And further, he added that he is now, quote, out of the woods, unquote. So this was really, after that, I think a lot of people got a lot of interest in this. The fact that he said he's convinced it saved his life. Prior to the emergency use authorization by the FDA, this treatment could cost a health plan over $1 million per treatment. That is, if it were even available to begin with, and it was not available in those plans. But the good news here is that, like with the vaccines, the government has indicated that once these treatments become more available, they'll be offered on all plans without cost sharing. The government expects to have at least 300,000 doses of the monoclonal antibody treatment available by late December. And there are two manufacturers of these treatments that received emergency use authorization from the FDA in November, Eli Lilly and Regeneron. And I should also add here that my wife tells me that Dr. Gray from Gray's Anatomy also just got the monoclonal antibodies on the show, and so hopefully they work out as well for her as they did for Ben Carson and the president. I guess we'll have to stay tuned for that, though. So we also thought this would be a really good time to give everyone an update on the status of the ACA, as well as other ACA updates that are important to be aware of at this time of the year. So I'll go ahead and kick this off, get us started with the Supreme Court update. You may have heard about on the news because it was a pretty big topic, as many of you probably saw, right? The ACA looks like it is likely to survive the most recent challenge to its constitutionality, at least based on comments made by the Supreme Court judges in oral argument in the case of California v. Texas. Chief Justice John Roberts asked questions, a conservative judge, as well, asked a lot of questions suggesting that, because Congress did not repeal the entire ACA when it eliminated the individual mandate penalty, that suggests that, not all of the ACA should be invalidated due to the one change, right? So what happened here, just some background, right? The Tax Cuts and Jobs Act eliminated, reduced the penalty for the ACA's individual mandate, right, which is that mandate that requires individuals to have health insurance or face a penalty. That penalty was reduced to $0 as part of TICJA, the Tax Cuts and Jobs Act, or tax reform. And of course, as a result of that, the Trump administration and several states alleged that the entire ACA must be struck down because it's unconstitutional, since it's dependent on being inseparable from this individual mandate, and once the individual mandate goes, the whole law must go. It must be held unconstitutional. Several states, including the state of California and other states, opposed that and said no, the individual mandate can be, it should be not inseparable, and you can sever the individual mandate penalty, and the rest of the law should stand. So, notably here, based on what happened in the oral argument, it seemed to suggest, and it's not always going to be the case, that what the comments of the judges are is, what the result is going to be when we are expected to get a ruling here by the end of June. But, the judges seem to suggest that they were in favor of keeping the ACA as is, that is, without the individual mandate, holding that it could be severed from the rest of the law. Specifically, Chief Justice John Roberts said, it's hard for you to argue that Congress intended quote, it's hard for you to argue that Congress intended the entire act to fall if the mandate was struck down, unquote. And conservative Justice Kavanaugh also made very similar comments to that effect. And so if Roberts and Kavanaugh join the court's three liberals in the court's eventual ruling, which is due by the end of June, then that would mean that the bulk of the ACA would survive. So very good news, at least for those who have become accustomed to the ACA, know how it works, and would prefer not to have all the disruption of having it go away. So that's it for the court decision. Dot. Do you want to? Yeah, we get to keep our jobs,
all of our
right?
hard work for the last 10 years.
Exactly.
For the last 10 years, we spent all of our time making sure our employers are, are compliant with the ACA, and now it would be turned down. That would just destroy us. So, Dan, I'll talk about the ACA, which, as you said,
Great.
is, still a part of the ACA. Information reporting. So, we all know it's that time of year again. Employers must be getting ready for the annual ACA information reporting. On October 2nd, the IRS released information about the 2020 filing requirements. Not really much has changed from last year. There was one new item where they did add new codes for reporting for an offer of an ICRA, that is the individual coverage HRAs that possibly employers could be offering, but we've seen very, very few employers implement these types of plans, so generally those codes do not apply, again, unless you have an ICRA. As in previous years, the deadline to furnish the 1095-Cs to employees is once again extended from the original January 31st, has been moved to March 2nd of 2021. But also remember, though, that the deadline to submit the forms along with the 1094-C to the IRS still remains in effect. For paper submissions, that deadline is February 28th, 2021, and for electronic submissions to the IRS, March 31st, 2021. Also remember that an ALE who submits 250 or more 1095-Cs to the IRS is automatically mandated to file electronically. Those under 250 forms have the option to submit either electronically or via paper. In addition to this extension for furnishing the forms, the IRS will again extend the good faith penalty relief for reporting errors in the 2020 calendar year. This has been around ever since this reporting came into effect. If the employer could show a good faith effort for why the forms were incomplete or why the forms were not submitted timely, the IRS, would give some reprieve for that. But however, one thing that is different with this year is that the instructions specifically indicate that this will be the final year that such a relief like that will be extended. The one thing that we were hoping, I know Dan and I have been talking a lot about this, and I think lots of people have ever since that individual mandate was reduced to zero, and what we're still kind of confused on is why the IRS is still requiring coverage providers and self-funded plan sponsors to continue to complete IRS Code 6055 reporting. So that on the 1095-C, that's the box 3, where a self-funded plan has to check the boxes for which months the employees were enrolled in. It's the carriers providing the 1095-B for the same purpose. Because it actually seems a little redundant and unnecessary, because if we are not imposing any type of individual mandate, why is that reporting still there? And then also, I think Dan and I are probably a little bit more hopeful than most people. We also were hoping that the IRS would issue some more relief or a more simplified process with the reporting, just, given the difficulties associated with the global pandemic. But unfortunately, it appears that, all of this relief, that there is nothing specific to, help with the pandemic or, anything that the IRS is willing to do there. So still, same process as usual. And then also one thing that just came up this week, don't have a slide on it, but it's something that we wanted to just mention as well, is that the IRS has recently issued guidance adjusting the annual PCOR fee. So the PCOR fee is the ACA required fee applicable to sponsors of self-insured health plans, including HRAs. So that annual dollar amount is adjusted on an annual basis, and the percentage increase is projected on a per capita national health expenditure. So for the new rate, it is for plan years beginning on or after October 1st, 2020 and before October 1st, 2021, that amount is now $2.66. So that's a 12-cent increase from the previous plan year. So as a reminder, that fee is payable annually by July 31st, but we always send out our e-alerts reminding our groups about that. Okay, so a couple of ACA requirements. Now we want to talk about the healthcare transparency final rule. So, you know, a lot of detail here. I'm going to go through this. Dan's going to jump in, you know, as needed, but things to definitely, you know, take a look at. Let's, you know, review all the requirements. We do have some time. You know, a lot of these don't go into effect until 2022, 2023, but definitely a lot of information and a lot of work, you know, in getting these in place. So the transparency and coverage rule attempts to educate or execute on Trump's administration's executive order on improving price and quality transparency in America healthcare to put patients first, which was originally issued in June of 2019. This final rule requires certain disclosures regarding prices and cost-sharing information for healthcare items and services provided by non-grandfathered group health plans and insurance carriers. The rule generally applies to traditional health coverage and does not apply to account-based health plans such as HRAs, including ICHRAs, or health FSAs, accepted benefits, or short-term limited duration insurance. So under the rules, there are two categories of disclosures. So there are disclosures to plan participants, and there's also disclosures to the public. So let's start with disclosures to participants. Under those rules, group health plans and issuers must provide certain personalized cost-sharing information to participants and beneficiaries in advance and upon request. The required disclosures must include the following information. They must, one, include estimated cost-sharing liabilities. This is the consumer share of the cost of an item or services under the plan or coverage. Second, the disclosure must include accumulated amounts. This is the consumer's accrued deductible or out-of-pocket payment amount, as well as accrued items or services for which the plan imposes a cumulative limitation. The accumulated amount also includes the enrollee's accruals towards any cumulative treatment limit on a particular item or service, such as services that have a limit on days, units, visits, you know, physical therapy, things like that. The third item is a negotiated rate. This is the in-network provider payment amount for an item or service. Note that the final rule, though, revised the definition of negotiated rate to mean the amount a plan or insurer has contractually agreed to pay for a covered item or service, whether directly or indirectly through a TPA or PBM or an in-network provider. So this also includes in-network pharmacy or other prescription drug dispensary for covered items or services. Also must include out-of-network allowed amount. So this would be the maximum amount a plan would pay for an out-of-network provider for a certain covered service or item. 5, also must include items and services content list. For bundled services, health plans would have to disclose a list of each covered item and service covered by a bundled payment arrangement. For example, with diagnostic imaging. This type of arrangement pays a provider a single payment for all covered items and services provided to a patient for a specific treatment or procedure code. And then finally, must include notice of prerequisites to coverage. So when consumers request cost-sharing information, health plans must inform them if the item or service is subject to concurrent review, prior authorization, step therapy, or any other medical management requirement. Then for the public disclosure, there are 3 items that must be included. The first must be the name or identifier for each plan option or coverage, so employer identification number or health insurance oversight system. Secondly, for the public, the disclosure must include billing codes. These are codes used to identify services or items, including CPT codes, national drug codes, or descriptive terms such as rapid COVID test, for example. And then finally, for the public option, the in-network rate must include the dollar amount of the negotiated or other applicable rate for each provider within the provider's national provider identifier with a tax ID number and place of service code. And as I explained previously, for bundled items and services, the rate by relevant code. The final rule adds a requirement to note whether the rate is subject to an alternative payment arrangement, and also clarifies that plans and issuers must include an underlying fee schedule rate when one is used to determine cost-sharing liability when the amount differs from the negotiated rate used to determine provider reimbursement. A lot of information there, a lot of detail that needs to be included. All right, so let's talk about these two, public versus participants. Like I said, there are two different dates. So for public requirements, effective for plan years beginning on or after January 1st, 2022, plans and issuers will be required to publish 3 machine-readable files, one for in-network provider negotiated rates, the second for data outlining the historical allowed amounts for covered items or services provided by out-of-network providers, and a third file for pricing information for prescription drugs. The files must be available free of charge and updated monthly. Then for participants, effective for plan years on or after January 1st of 2023, plans and issuers must make required information available without a fee in one of 2 ways. First, through an internet-based self-service tool, and 2, in paper form by mail upon a consumer's request. The self-service tool must provide real-time responses, be searchable by billing code, descriptive term, and provider identity, and interact with consumer input to deliver meaningful cost-sharing information depending on any tiering, network status, location of service, dosage, or other factors. The self-service tool must permit the consumer to refine and reorder results based on geographic proximity of in-network providers and the amount of cost-sharing liability. Also, if a consumer requests information in paper form, the plan or issuer must mail the cost-sharing information no later than 2 business days after the request is received, and may limit the number of providers included in the information to not less than 20. Plan issuers may provide consumers the option to receive information through other methods, such as phone, face-to-face, probably not so much, fax, or email. And then, due to the extensive nature of the required disclosure, the departments include a staggered schedule for providing the required participant disclosures under the rule. For plan years beginning on or after January 1, 2023, plans must make this information available for 500 items and services listed in the rule. And then beginning for plan years beginning on or after January 1st, 2024, plans must make information available for all items and services. Some additional items were included in the transparency rule, MLR shared savings. So beginning with the 2020 medical loss ratio reporting year, issuers may reduce the MLR rebate by including in the MLR calculation any shared savings payment made to an enrollee for choosing a lower cost, higher value healthcare provider. This rule may encourage issuers to incentivize enrollees to shop for expensive providers and to share those savings with enrollees. The shared savings could be, for example, a gift card, a cost-sharing reduction, or a premium credit. Errors and omissions, so for failing to meet these requirements. So the Labor Department will enforce the transparency rules for ERISA-covered group health plans, while Treasury will enforce the rules for certain church plans. As with other ACA rules, the DOL can refer violations to the IRS, which can assess daily penalties of up of $100 for participant for non-compliance. However, there are good faith protections, and plans will not fail to comply or face enforcement action if the plan made an error or omissions in a disclosure while acting in good faith and with reasonable diligence, provided the information is corrected as soon as practicable. Under these rules, fully insured plans are not specifically required to comply with, as most things related to fully insured plans, the onus will be put onto the carrier to handle and implement and get all of this up and running. But sponsors of self-funded plans do need to comply, but the rules allow a self-funded plan to satisfy the disclosure requirements by entering into a written agreement with another party, like a TPA or a healthcare clearinghouse, to provide the necessary information. However, please note, though, that if the other party fails to provide information in compliance with the rules, the plan will be responsible for the violation unless one of the good faith protections discussed above does apply. In contrast to that, if an insured plan has a written agreement requiring the insurance carrier to provide the information, then the carrier will be responsible for any compliance failures. And then finally, this rule includes requirements similarly to those disclosures for EOBs and does overlap with the current hospital price transparency rules. So a lot of information, like I said at the beginning, a lot of requirements, a lot of system changes that are going to need to be implemented. So, definitely something to be thinking about. Dan, do you want to talk to us now about some of the other developments that are currently out there?
Yeah, thanks, Dot. Yeah, that was comprehensive. Thank you for that. It's a lot of information. Obviously, but we're here at Corporate Synergies to help you through that, understand how those rules work, but yeah, that's just a lot of information. Unfortunately, we have some time though on that. Great. So these are just some of the other developments that we're watching. Not necessarily the biggest things that are out there right now, but just things that we're watching pretty closely. The first is a case about ERISA preemption. And what is ERISA? Just to give some background here, what is ERISA preemption? That sounds very fancy legalese, but really all it means is that if there's a state law that has deals with a subject that's very, very similar to, almost exactly the same as what ERISA covers, ERISA can preempt the state law, essentially overturning and invalidating that state law because it's the same as what ERISA does as a federal law. And so we say ERISA preempts the state law when, of course, they're so similar, and that's pretty much how it works. So this first case, Rutledge v. Pharmaceutical Care Management Association, which had oral argument on October 6, 2020. This is a case about ERISA preemption of state PBM regulation, and the facts are pretty straightforward here. Pharmacies were alleging that they're losing money to PBMs because the PBMs were setting costs lower than the pharmacy's attainable acquisition cost, and so the state of Arkansas enacted this law called Act 900, designed to regulate PBMs, and of course, making sure that PBMs do not engage in these kinds of pricing practices. And of course, the PBMs argue that ERISA should preempt this state law, right? Because the PBMs didn't want to be regulated by this law, so they said, look, ERISA should preempt the state law because ERISA governs rules that apply to group health plan costs, and prior to this Supreme Court case, there was a case below in the 8th Circuit that agreed with the PBMs and ruled that the Arkansas's Act 900 was preempted, and then the Supreme Court agreed to hear the case, and based on oral argument that was recently held, it looks like the court is really focused on two cases, New York, two other cases on ERISA preemption that could end up deciding how this goes. One is called New York v. CBS versus Travelers Insurance, which held that states can regulate hospital prices, even though those prices might ultimately be passed on to an ERISA plan. So Arkansas is really saying, hey, look, that's us, right? We're the same as in that situation. Let's keep the law, save it from ERISA preemption. Then on the other side of the argument, the court is focused on a preemption case decided a few years ago when Justice Scalia was still on the Supreme Court, Gobel versus Liberty Mutual. Supreme Court case holding that a Vermont reporting statute that resembled ERISA Form 5500 reporting, that Vermont statute was preempted by ERISA and therefore invalidated. So we're going to obviously stay tuned for that ruling, but that's something we're watching very closely. And another development that we're watching, another thing is, of course, what's happening at the Supreme Court, right? And I think we all probably saw in the news that Justice Ruth Bader Ginsburg died and was replaced not by Amy Coney Barrett, nominated by the Trump administration, by President Trump. And that is, of course, I think of course, that is going to have a big impact on employee benefits decisions. One case that we watch, although not necessarily an employee benefits case, already seems to suggest that new Justice Amy Coney Barrett, or let's just call her ACB to make it easier, ACB will have a big impact on the court. In this case, which is Roman Catholic Diocese of Brooklyn versus Cuomo, a case in the Supreme Court decided on November 25th. The Supreme Court held that restrictions previously imposed on New York places of worship by Governor Andrew Cuomo of New York during the coronavirus pandemic violated the First Amendment rights to, free exercise of religion. The decision in a 5-4 vote really heralded the first significant action by the new President Trump-appointed ACB, who cast the deciding vote in favor of the Catholic Church and Orthodox Jewish synagogues that wanted to continue to engage in religious practices despite the state COVID-19 restrictions. And while the specifics of this case really, look, they're not really necessarily specific to employee benefits laws and regulations, the ruling does show the direction that the court is heading into, that, a direction more focused on preserving religious freedoms, which, of course, could make it harder for employers to enforce a mandatory vaccine program, without broad religious freedom exceptions. And of course, we could see similar rulings in benefits cases involving the ACA's contraceptive coverage mandate, as well as rules about abortion coverage on medical plans. So we're watching that development very closely. And then just real briefly here, there's a couple of other things we're watching. Changes to Medicare plans. One thing that happened on November 20th was that CMS issued its final most favored nation rule, which aims to reduce the cost of prescription drugs in Medicare Part B plans by tying prices to a new FMN model, a most favored nation model that really relies on international price competition. Really kind of looks to an index of international prices and tries to find sort of the lowest price among them. The new pricing model is intended to be phased in over time, but it is expected to face significant legal challenges before it's implemented. And if it were to be implemented, it would probably have an effect on reference-based pricing. Although we still, it's probably too early to tell if this thing is going to pass. Most folks out there are saying it's probably not going to work. There's also a final drug pricing rebate rule that was issued on November 20th that intends to force PBMs and insurers to pass rebates that they receive from pharmaceutical companies to Medicare Part D patients at the point of sale, which will directly benefit patients with high out-of-pocket costs rather than just simply using those rebates to lower overall premiums or provide other benefits. And that rule is scheduled to take effect in 2022. So we're watching those pretty closely. A lot of these types of rules, though, have been challenged in the courts. It's not necessarily so clear that they will go into effect as they were written. Okay, so now we are at the major part of our presentation today. We wanted to talk about the election. We're obviously not going to get into all of the political news of the day, that whether or not, of course, there's any legitimacy to the claims by the president that there was massive fraud in the election. Since, as we mentioned earlier, we see that as really political. We don't really get into politics on this show, so we'll leave those things aside and assume for now that the President-elect Biden is going to be our next president. I will, however, question one of the president's recent decisions, which is why the extremely small desk at your recent Thanksgiving press conference. Right, Don? I mean, that thing is like... Yeah,
it is, seriously.
What's up with that?
Right. Why not a podium or even,
exactly.
a bigger commanding desk?
Exactly. I don't get that at all. Anyway, let's start off with taking a big picture look at the Biden administration's major healthcare policies and other initiatives that will likely have an impact on your organization's benefit plans. And then as we get closer to the end of the program, we're going to go through each of the major ones of these that could possibly have an impact and kind of discuss those in more detail. And I'll get started with that. But before I do that, I think we should mention here that this was a very historic election. Over 80 million votes for the Biden-Harris ticket, which is really unprecedented. Also, with such a big turnout, it was unusual in that, while the Democrats retained control of the House, they actually lost some seats there, and also almost broke even in the Senate, which is going to come down to runoff elections in Georgia in January. And of course, in addition to the fact that we didn't see a blue wave as many pollsters had predicted, the votes showed that we had an incredibly divided country where, even though President Trump lost the popular vote in Electoral College, he still managed to get over 73 million votes. And of course, the election resulted in the first female vice president in Kamala Harris and the first female secretary of the Treasury, Janet Yellen, which is truly unique. And all of this happened in the middle of a pandemic. So really just an extraordinary moment in the news right now. So let's talk about some of these initiatives, right? Here's what the Biden administration wants to do for health insurance. They want to create a new public insurance option on the exchanges. And what this is essentially an expansion of the ACA state Medicaid expansion rule, which essentially allows certain, originally as written, allowed certain states to opt into more Medicaid funding, and some states did not opt in and were not considered expansion states, so they didn't get as much funding for Medicaid as the other states. And so what this public insurance option does is essentially expand the ACA state Medicaid expansion to the non-expansion states, so that the low-income individuals in all of those states will have greater access to exchange coverage. Also, as part of the healthcare options, Biden wants to expand access to and increase the value of the premium tax credits that are available on the exchanges, and Dot's going to talk about that a little more detail a little bit later. He also wants to expand access to and eligibility for exchange coverage, decrease or eliminate some alternative healthcare options introduced during the Trump administration, such as short-term limited duration insurance and potentially also association health plans. ACA, there's also many other ACA-related changes, which are just generally referred to as ACA stabilization initiatives, which mean essentially a return to Obama-era ACA rules, including reinstating protections for contraception, prohibitions on sexual orientation and gender identity discrimination, and things like that. We're going to be obviously watching all of those things very closely. And then as far as other healthcare and benefits initiatives, really these top I would say four. Let's see. Yeah, actually, really, I would say the top four are going to be in the short term. Really, the ones at the top of the Vice President Biden's. President-elect Biden. Still hard to get used to saying President-elect Biden. President-elect Biden's legislative agenda. These top four things really are at the top of the list outside of the ACA, which are: one, reduce prescription drug costs, including on both high-priced biotechs and generics, and that's something that he's really put on the campaign website as being a high priority. Increase access to and relax rules on prescription drug importation. We've seen that was something that the Trump administration was also very much interested in. I think both of those, and then increase prescription drug price transparency, which that last rule that Dot just went through, that was still a Trump administration rule, right? So again, a lot of those things, are things that I think are probably going to stay in a Biden administration, all those rules that Dot just talked about. And then to end surprise medical billing, which we've been, we're going to talk about a little bit later, but that's obviously, those are the ones that I think are really kind of at the top of the list as far as things he wants to get done right away. He also has talked a lot and written a lot about on his campaign site about increasing the affordability of long-term care, and expanding access to mental health coverage, including addiction treatment coverage, and increasing enforcement of mental health parity rules. He also hopes to increase and expand the education benefits and student loan benefits that are out there. While we still don't have a lot of detail or specifics on employer-sponsored education benefit plans or things like that, there has been a lot of talk of several different options that the president-elect is considering to reduce the debt load on federal loans. And while Biden has said he would be amenable to dropping the federal loan debt by $10,000 through some kind of legislative process, Chuck Schumer and other Democrats in Congress are urging him to move forward with a $50,000 reduction to help those who are suffering from high federal student loan debt loads during this pandemic-caused recession. They're asking him to do that on day one. I'm not sure if that's going to happen, but certainly there's a lot of need right now in light of this recession that we're in and from the pandemic to do something on student loan debt. So that is going to probably be a higher priority once he comes into office. And then when it comes to pandemic response, the big thing here is the goal is to federalize the response to the pandemic, to make the rules more uniform and easier to understand, decrease the reliance on state governors, which sort of creates a sort of patchwork of different rules and regulations in different states, and makes it very difficult, I think, especially for a lot of the HR and benefits managers for larger employers operating in many different states. One thing that I've been reading about is, we've seen a lot of people who are looking to nationalize OSHA, create a federal OSHA standard for COVID-19, which will help make things more uniform. We'd also like to depoliticize the use of PPE, which is something that I think we're going to, see more of, more people in public positions wearing masks. And then when it comes to what will Congress look like, it's very, very close, right? So while Democrats have control of Congress, it's not a big majority in the House. I'm sorry, Democrats have control of the House, I should say. It's not a big majority, so it's not like there's going to be, there wasn't any kind of giant blue wave or anything like that. It's very, very close in the House. In the Senate, while Republicans technically have a lead in the Senate, there are these two Senate runoff elections in January in Georgia that we'll be watching very closely, which could tilt it in favor of the Democrats. But in either case, it will still be a very divided Senate, very evenly divided Senate, and relatively evenly divided House. And that, of course, means that it will really come down to the ability of President-elect Biden, his ability to implement many of these initiatives that we just talked about are really going to depend on his relationship, right, with the Senate Republicans and Mitch McConnell. Unfortunately, Biden and Mitch McConnell have a history of working well together in the past. And Mitch McConnell was the only Republican to show up at Beau Biden's funeral, indicating that they are very close and have a very close relationship. Just very briefly, we're going to talk about this, Biden cabinet. Obviously, when it comes to employee benefits, the big roles there are DOL, HHS, and Treasury. The DOL, it's still too early, I think, to speculate on that, so we'll just kind of skip that one. And HHS, which includes CMS, OCR, other agencies that regulate health plans, this basically just happened like a day ago. Basically, the New York Times broke the story that President-elect Biden is going to nominate former Congressman and California Attorney General Xavier Becerra, the Secretary of Health and Human Services. He's very popular in the Democrat Party and was being considered by Governor Newsom to take over Kamala Harris's seat. And more specifically, as the AG of California, he was the top law enforcement official there. He has repeatedly gone to court to fight the Trump administration's policies on health care. In fact, earlier this year, he led the coalition of 20 states and D.C. that asked the Supreme Court to review the circuit court decision below in the case of California v. Texas that we just talked about to invalidate the ACA. So he is a strong supporter of the ACA and has a real strong history there. And of course, Janet Yellen, selected, as we talked about before, to oversee Treasury, is really a bipartisan pick. I think she's popular among both Democrats and Republicans, has experience with policymaking. She was former Fed chair. She was on the 2008-2009 financial crisis policymaking committee. So definitely he's chosen people with a lot of experience here. And on the pandemic task force, he's the general thing here is he's done, I'm not going to go into each person here, but he's selected a lot of people from the Obama administration to really lead the pandemic task force. Notably, Rick Bright, a vaccine expert, was selected to the 12-member team. And in case you don't remember that name, he was a whistleblower in the Trump administration who resigned from his post at NIH in April over his concerns about the Trump administration's handling of the pandemic. So that's kind of interesting. And I think the takeaways here, this is really where Don and I kind of wanted to zoom in a little bit on some of the big things, right? What are some of these big things that are really going to have an impact on your organization and your plans? So Don, why don't you start us off with the ACA and the ACA employer mandate?
Sure. So for the most part, it's probably clearly to be said that the Biden care will look a lot like Obamacare. You know, a closer look at his proposals do show some areas where employers and plan sponsors are likely to have some concerns, some potential problems. And so I think we should talk about those first, and then we'll go on to, you know, a little bit of additional proposals. So first of all, one thing is very clear. The new public option that they are proposing is not a code for Medicare All or Medicaid for All. Biden made it very clear during the debates that he wants to keep employer-sponsored health care intact, as well as the structure of the ACA as we know it today. Biden believes individuals should have another better choice, whether an individual is covered through their employer, buying their own insurance, or going without coverage altogether. And that choice will be to purchase a public health insurance option like Medicare. As similar to Medicare, the Biden options will reduce costs for patients by negotiating lower prices from hospitals and other healthcare providers. It also will better coordinate among all patients' doctors to improve the and quality of their care and cover primary care without any co-payments. And undoubtedly, this will bring relief to small businesses struggling to afford coverage for their employees. Additionally, the public option would bring relief to part-time and temporary employees who are working under the 30 per hours per week who are not required to be offered coverage by their employer. Now they'll have more health options than before. Dan did talk about the premium tax credit and the exchanges. Biden is looking to increase the value of tax credits to lower premiums and extend coverage to more working Americans. Today, families that make between 100 and 400% of the federal poverty level may receive a tax credit to reduce how much they have to pay for health insurance on the individual marketplace. The dollar amount of that financial assistance is calculated to ensure each family does not have to pay more than a certain percentage of their income on a silver plan. But it's believed that these shares of income in the silver plan deductibles are too high. So basically, what Biden is looking to help the middle class families by eliminating the 400% income tax on tax credit eligibility and lowering the limit on the cost of coverage to 8.5% of income. This means that no family buying insurance on the individual market, regardless of income, will have to spend more than 8.5% of their income on that coverage. Additionally, Biden will increase the size of tax credits by calculating them based on the cost of a more generous gold plan rather than the silver plan. This will give more families the ability to afford more generous coverage with lower deductibles and out-of-pocket costs. Also, we want to look and be concerned, about the affordability threshold that we're all working, all of us helping our employers work with. Employers should watch for changes to that affordability threshold for employee contributions, since that's currently linked with the safe harbor that some employer plan sponsors use to maintain compliance with the ACA. For 2021, the current federal poverty level affordability safe harbor is about $104.53. That's the magic threshold, bearing opt-out credits and certain wellness initiatives that provides a cap on employee contributions for the single coverage in order for an employer to meet the federal poverty line affordability safe harbor. But if Congress agrees to drop the percentage down to 8.5%, that could leave us, for example, with a maximum employee contribution for affordability of only $90.38 in 2021. So that's potentially a 14% increase in employee contributions, which could lead employers to shift cost sharing elsewhere. So Dan, you want to talk about prescription drugs and surprise billing?
Yeah, and I think we can kind of go through this quickly because really a lot of these things are the same initiatives that the Trump administration wanted to do when it came to drug importation, transparency, drug costs, things like that. So we don't need to really get into a lot of detail here. One area that is very, that has a high priority for them is surprise medical billing. And just for some background here, in case you're not familiar with the initiative to stop surprise billing and you haven't attended our past webinars, right? This involves what occurs when sometimes patients are unaware that they are receiving care from an out-of-network medical provider, typically occurring in emergency hospital visits when the patient goes to the nearest in-network hospital but doesn't realize the specialist at that hospital is not part of your health plan's network. Then, of course, gets a sees an out-of-network doctor with any kind of understanding of that and gets that surprise medical bill. But we've seen many legislative proposals and initiatives in this area at the federal level over the last several years, and they all seem to really get caught up at that last piece of how to handle disputes, whether through arbitration, or by pegging costs to a certain Medicare rates or things like that. And so as a result, right, Congress hasn't really been able to agree on a federal approach, and what we have now is a patchwork quilt of state regulation on this issue. It's one of the Biden administration's top healthcare goals is to fix this problem, help find a federal approach that works for everyone, preempts a lot of these complicated state rules, and really creates more uniformity. So that's something that we're going to be watching very closely in the future. So, Dot, you want to talk about the changes to long-term care insurance?
Sure. So, as we all are very well aware of how expensive, private long-term care insurance is, and many Americans lack access to that. So, what Biden is looking to do is expand access to and to defray the cost of long-term care in two primary ways. First, he would establish a $5,000 tax credit for informal or family caregivers to cover out-of-pocket costs. And second, he would increase the generosity of the current tax benefits for purchasing long-term care, including insurance paid for out of retirement savings. So the Biden campaign does not specify how it would make existing tax benefits for long-term care insurance more generous, but for purposes of estimating the cost of this, they're assuming that the cost is similar to that of the Bush-era proposal to move the long-term care insurance deduction from an itemized to an above-the-line, which hopefully would remove it from income before the standard or itemized deduction. So, obviously a lot of tax scenarios there. Still, waiting for additional information on that. And then also, we're also looking at some major changes here that are likely to be concerning to employers sponsoring self-insured plans. A Biden administration would increase federal health care spending in several other areas, most significantly in relation to mental health coverage for rural health care and mental health funding. So for instance, he would double federal funding for community health centers, for which more than half are located in rural communities. He would also increase funding to build new health clinics and deploy telehealth services, reverse scheduled cuts for hospitals and serving those without insurance, and adopt several other provisions which would support rural hospitals and expand care in rural communities. Also, Biden's looking to improve enforcement of mental health parity laws and expand funding for mental health services. According to the Committee for a Responsible Federal Budget, they estimate costs approximately $200 billion over a decade. And as of today, mental health parity rules are not really enforced, and sponsors of self-funded plans would likely have to make changes to better ensure that their health plans and programs do not come under scrutiny here. So, definitely a big issue. Dan, you want to talk about the changes to taxation?
Yeah, I think the main areas we're really going to see changes to the tax code to make benefits more affordable really are things related to prescription drug costs, changes to pharmaceutical manufacturing rules, including the elimination of the Pharmaceutical Corporation's tax break for advertising spending, the changes to long-term care that Dot mentioned, mental health, like Dot mentioned, and education benefits. So I think those are kind of like our top five. We also, don't really have time today to talk about some of these other things in more detail, but we've kind of already touched on them in the past. One big thing, of course, is just really enforcement of benefit plans, right? I think, there's going to be more funding going to enforce compliance, with benefit plan rules. So we'll see, most likely we'll probably see more audits from these agencies that we talked about. So since we only have about a minute left here, let's just talk about the big key takeaways from today, right? One thing to know, right, Biden care isn't simply return to Obamacare, right? As you've learned today, it's different. And so stay tuned for how these changes are going to happen over the next months. And then the Supreme Court right has changed, right? ACB is an RBG, and we're probably going to still see challenges to Biden initiatives on religious freedom grounds that could impact your plan. Finally, the pandemic isn't going to end on January 21st of 2021 when Biden becomes president, so there's still things that we have to prepare for, and remember those special rules that are in effect in light of the national emergency. And look, a lot still depends, everything we've talked about today, right, at the end of the day, still depends on that January runoff elections in Georgia for the Senate, and that dynamic between Biden and Senate Republican leadership. So still a lot of question marks for today, as we go into the year ahead. But we'll be watching each of these things very, very, very closely and keeping you updated all along the way. So I don't think we have time today to talk about the frequently asked questions, but we do want to help you find some additional resources on many of the topics we discussed today. You can check them out at our Compliance Resources Center page, which is at the top link here on the slide, as well as these other helpful links for additional information. So thanks for joining us today, and stay tuned for more updates and to learn more about our programs for next year, including next year's quarterly review with Dan and Dot, where we're going to hopefully continue this format, keep it conversational. So thank you, and be safe out there.